Good evening, everyone. I hope that you can hear me well. First of all, I'm so sorry that I'm not there in person. I was hoping to be there with you and be able to discuss and take questions, but unfortunately, COVID is still with us, and today it's with me. So I'm here, and I hope that you get something from it anyway. So my name is Prue. I'm a pediatrician. I normally work in East London, and in 2021, I took my first assignment with Médecins Sans Frontières in the Central African Republic. So I'm going to tell you today the story of one of my first patients, who I'm going to call Mariam. And I'm going to tell you the story of looking after her. But the other thing that I'm hoping that you can go away with from today is to have some knowledge, something in your mind about the Central African Republic. This is a place that is really the definition of a neglected crisis. So I want to tell you something about this place and for you to leave with that in your mind. So the Central African Republic is a very big country, size of France, but very sparsely populated rural country, about 5 million people. And as the name describes, it's in the middle of the African continent. But despite conditions which put the Central African Republic right at the bottom of almost any measure that you can find of wealth, health, well-being of the population, it remains essentially invisible to people in kind of rich Western countries like the UK, donor countries, and unfortunately, it is consistent that funding calls for humanitarian aid to Central African Republic are missed. Year on year, there is not enough money going to the needs of this population. MSF has been in the Central African Republic for quite a long time. So I think we were first there in 1997. But our most recent reasons for being there are the outbreak of civil war, which began in 2013. In 2013, there was a coup. The government was overthrown by a kind of amalgamation of armed groups coming from the northeastern part of the country. They came into the capital, overthrew the government, and triggered off a cycle of violence and displacement across the whole country, which has been going on ever since. And this is a kind of multi-dimensional, complex conflict along religious, ethnic, geographical lines, the legacy of which continues to this day. And the stats on this are quite striking. The population is essentially living outside of control of the government. The vast majority of the country is outside of government control. And about 1 in 4 of the Central African population is displaced. And today, about 3/4 of all of the health services in the country are being run by NGOs like MSF. Now, from my point of view as a pediatrician, one thing that's really important for me to know about the Central African Republic is that the population is really very young. This is a population in which the average age is about 18 years, and something like 1/5 of the population are children under 5. So a very young population and a lot of children, so a large burden of pediatric illness in this population. And it's a very dangerous place to be a child. Imagine this scenario, something actually quite common among families that I saw. There's a pregnant woman. She's undernourished. She's had malaria during her pregnancy, and then she gives birth at home without any assistance from a skilled professional. And because of these reasons, her baby's born small and vulnerable. Birth defects don't go identified, they're left untreated. And because of her nutritional status, she struggles to produce enough breast milk, but just manages to get this baby through the first months of life. However, violence coming into their village means that they have to flee, and the baby misses all of the routine vaccinations that they should have had in the first month's year of life. And she just keeps getting sick over and over again. But the last time that they went to the local health post, the army had taken over this structure as a military shelter, and there were no health personnel and no resources for anyone to look after her at that time. And luckily she recovered. But then the next insult comes. There's the dry season. This is a period in which crops don't grow. And nowadays the rains are becoming less and less predictable, the periods of dryness ongoing, the family goes hungry. And the young children either become very thin, malnourished, or bloated because of not having enough to eat. The older children go out and they're trying to sell anything really that they can to make money for the family, and they don't go to school. And they're watching the older children in their communities looking for a sign of what their own future holds. And they see some of these kids have been kidnapped, they've gone to work in the mines, or they've gotten killed in fighting. And the girls are scared about what will the men do. And they all wonder when they grow up whether anything's going to be better. And the emotions of grief and fear are part of their daily lives. And hope is little, few and far between. So this kind of family story, this scenario, is the backdrop to Mariam's story when I met her. So I went to Bambari, which is the second town of Central African Republic, and I was working in the hospital as a pediatrician. And it was about my second week of being there. I was really still trying to figure things out. How did the place work? What was my role? How was I going to be able to do my work? And after our morning handover, we had a meeting at 7:30 every morning. After that, I decided to go and this day wander around each of the departments to get a bit of a feel for how they worked and what was going on that day. This wasn't something I always did. I just did it that day. And I went along with my nursing colleague, Corinne, one of the nursing managers, also from the UK. And we went first past the triage section of the hospital, and the triage is essentially like our A&E department. And it was at that time in this kind of semi-temporary tents made of kind of this hard fabric. And so we went in, we dip under the low-hanging doorway, fabric doorway, and you go into this kind of thick yellow light of the triage room. And it was eerily quiet that day. There weren't the normal patients kind of lining up outside, children, parents, people waiting to be seen. It was quiet. And I went in and I could see Gilles, one of our very excellent nursing supervisors, in there. And I could see that he was working on a patient over in the kind of resuscitation area of the triage. And so I approached just to see what was going on. And I could see that there was a little girl there, maybe 5 years old. This was Mariam. And she looked a bit pale. She wasn't really moving. She was wrapped up in a survival blanket, a kind of shimmering goldish survival blanket. And I could see that she had some kind of plastic tubing, a cannula in her mouth. And that was to keep her airway open. And at that moment was when I started to feel quite worried. This is a sick child. And so I said to Gilles, what's going on? What's the story? And he said, severe malaria. She's unconscious. Her blood sugar is so low, I can't get a reading on the machine. Her hemoglobin's 1.5, and it should be something like 10 or 12. He'd already given her a glucose infusion. So I made a quick assessment myself. And it goes like this: A for airway. So the airway's open, but she's unconscious. That's why he's put the plastic tubing in, to make sure that it doesn't get obstructed. B for breathing. Okay, she's breathing, but it looks kind of slow and the movement of her chest isn't quite normal. And I tried to get an oxygen reading with the normal saturation probe on her finger, testing all the fingers, thumbs, ear. Nothing's coming up. Her fingers are so cold and shut down that it's not giving me anything. So I move on. C for circulation. Well, I can just about feel her pulses. They're there, but it's pretty weak and it's going kind of slowly. And I'm starting to feel more and more concerns. Temperature, 33 degrees, far below the normal. Blood sugar, again, we're checking with the machine. It just says low. It can't even give us a figure. It can't figure out how low it actually is. So I'm worried. This is a child who is about to go into cardiac arrest, and she needs blood. She needs blood urgently. And Gilles tells me that he's already sent the mother to the transfusion lab to get her own blood tested and to give a donation. So I say, how long is it going to take? And he says, maybe 15, 20 minutes, not so long, but we don't have that much time. And so we start a debate between ourselves. Basically, we know that we need more people and we need more stuff if we're going to save the life together of this child. And really, we need to move the patients, because here in triage, we don't have everything that we need and we don't have everyone that we need. But if we move the patient, we need to carry her, probably just in our arms, up the hill, up to the intensive care ward. There's no paved corridors, there's no trolleys with wheels to move patients around. And so that journey itself is a risk for her deterioration. And, we're dithering back and forth. What should we do? And Gilles just insists, let's move the patient. And I'm new, and I just, do what Gilles says. So we go. And I send Corinne, my nursing colleague, ahead, and I say, please run ahead, tell intensive care we're coming. They need to make a bed available, and they need to be themselves ready to receive a sick patient, all hands on deck. And so she runs ahead of us. So we get to intensive care. There's an empty bed, just a big wrought iron, adult-sized bed. The nurses are there, they're on standby. We reevaluate. Again, I'm putting the probe on her feet, her fingers, trying to get some numbers, some information. But she's so cold, her circulation's shutting down, and I can't get a reading. She's deteriorating. And the blood still isn't ready. So I'm checking her again. Her pulse is now getting to the point where we might have to start giving her CPR. And so I just start to think that we need to do something a bit unorthodox here. We need to give her some fluids into her IV cannula and just push them in fast to reboot her circulation while we're waiting for the blood. And the team understandably looks around and they look a little bit hesitant about this plan. But someone goes and they grab a 50 ml syringe, a big syringe, and a bag of fluids, and they start pushing it through. And finally, a bag of blood arrives. But before we can give it, we have to check that this is going to be the right match, the right blood match for her. But it just seems impossible to get that check done. We have to take a prick of blood from the end of her finger, and nothing's coming out. So just squeezing to get that 1 or 2 drops that we need to do the check is taking forever. And thankfully, at that moment, Junior, another amazing nurse supervisor that we had in Bambari, he came along, he took charge, and he got the check done. But at this point, I'm watching her. I'm standing at the end of the bed while the nurses are around doing the things that they need to do. And I'm watching her, and I can see that her breathing's changing. And she started to gasp. And this is a kind of infrequent, deep, agonal kind of breathing. And it's time that we have to start supporting her breathing. So Corinne goes with the bag and the bag valve mask you might have seen, and is doing breathing for her. Nurse Patrick, he comes along, he's attaching the end of that bag valve mask to the oxygen concentrator. And then Solange, one of the other nurses, she gets the suction device to come and make sure that we've got the nice, clear, free of secretions in the mouth. And this suction device requires her to stand on the pedal with her full body weight so that we get the suction through the tubing. And the team start to get the transfusion ready, and they're priming the lines that we need to give it. But me and Junior, we're standing at the end of the bed and we're looking at her, and we know that unless we do something quickly, that we're not going to save Mariam's life. And so together we decide on something difficult. We decide that this is one of those rare circumstances that we need to push her blood push the blood through her IV line fast, syringe by syringe, quickly, not over the standard 3 hours or 4 hours that you would normally take to give a blood transfusion. This is not the safest way of giving blood. It's not a good way of doing it in the best kind of clinical practice. But in this scenario, it's the only thing that's going to give us a chance as a team to save Mariam's life. And they again, look unsure. But Junior steps in. He doesn't hesitate. He gets his gloves on. He snaps them on. He instructs his colleagues what he wants them to do, and he begins. He sits down next to Mariam. He takes her arm where the line is attached. One nurse pulls down 20 mils of blood from the bag, hands it to Junior. He pushes it through and hands back the empty syringe, ready to receive the next one. And so the cycle begins, pushing 20 mils by 20 mils blood in through the IV line, and this cycle goes on. And I'm watching nervously. And I've got the probe. I'm attaching it to her feet, looking at it obsessively. And finally, I start to see this little flicker. Some numbers are coming up on the screen. It's picking up something. And the numbers aren't good, but they're numbers. They're there. This is progress. So now we're on the third or fourth cycle of the blood going in by the syringe. I'm just obsessively repositioning the probe. Got to find some numbers. Got to get that reading that's telling me something's going right here. And I'm just feeling the pulses in her feet. And finally, I think, oh yeah, I can actually feel a pulse in her foot now. I'm sure she's looking a little pinker, less pale, and I'm pretty sure she just moved her arm. And then finally, I can see on the saturation probe the numbers that I'm hoping for, things starting to look better, and I reassess. So airway, A for airway. Now she's not unconscious, her airway's open, she doesn't need that plastic tubing anymore, we take it out. B for breathing. She's now breathing without assistance. I can put the probe on and see that her oxygen saturations are 95% normal. She doesn't need support. C for circulation. Heart rate's coming up now into the normal range, 85, 95, 100. Blood sugar, we record it. Okay, it's low again, but we give another glucose infusion and it comes back into the normal range. And finally, her temperature is up to 36.5. I can see her eyelids are fluttering. She's breathing, her heart's beating, she's alive. And so we decide finally that we can give the rest of the blood in the normal way. We've done the bit that we needed to do for the emergency, and I breathe out, exhale, after all of that adrenaline. I take a few steps back to go to the desk. I need to somehow sort through what's just happened and write it down, document what we've done together. And I position the saturation probe in such a way that I can see from where I'm sitting at the desk, the numbers there, reassuring myself they're still okay. And as I'm writing, I see some movement from her bed. And just like that, Mariam just sits up in the bed, completely alert, eyes open. I'm thinking, oh gosh, like, is something wrong? What's happened? She looks kind of scared. And then she just says, I'm thirsty. Can I have some water, please? And everyone on the ward just laughs and is happy to finally see that she's kind of recovered. So Mariam survived, and we all had a skip in our step that day. We couldn't stop talking about her. And the community of Bambari and the staff of Bambari Hospital, they've seen a lot of sick children die. And that day, a very sick child indeed survived. And there was a sense of hope. There was a sense of hope in the hospital among the staff. And for me, at the beginning of my assignment with MSF, the hope was one that, despite all of the challenges that I was just starting to encounter and understand, I could sense that as a team, we were going to be able to save more seriously unwell children. And for the nurses who worked in Bambari Hospital for so many years, having the support of an organization which is providing the technical resources, medicines, training, a blood transfusion service, for them to be able to do their job well, that empowerment, that is also a cause for hope. But of course, the most important thing was that for Mariam and her family, there was hope coming from the fact that they knew now that there's a hospital in their community that has the staff and it has the resources to be there for them when they're sick. And even though I know that it's not enough to address all of those dangers that children are facing in Bambari and across the Central African Republic, this is just a little piece of hope. So thank you. I'm going to show you some images. I'm hoping if I can figure out how to share my screen well, I'm going to show you some pictures from the hospital. So I'm hoping you can see this. Oh no, I've gone there. Here we are. So this is just to show you where the Central African Republic is, right in the middle of the continent with the surrounding countries here. And this is what the outside of the hospital looks like. So it's the same entrance which the patients use and which we use as staff coming in and out. And that's one of the MSF vans going out there. And here is the triage that I was talking about at the beginning. So you can see these kind of semi-solid structures. This is where all of the kind of A&E emergency care was happening for the first kind of months that I was in Bambari. We then built a kind of permanent structure, which is where I'm standing taking this photo, which was more appropriate once we were able to do that. But this is where we saw Mariam when she first came in. And this image is showing the inside of the hospital grounds. And you can see for Mariam, I hope you can see my mouse, but for Mariam, we had to carry her up from this area, up this hill. And the intensive care is some way behind where this photo is taken from. So you can kind of get a sense of the terrain and the infrastructure of the hospital that you have to deal with when you're moving patients around. And then finally, there's this image, which is taken from the intensive care ward of Bambari Hospital. The intensive care ward's only for children. And you can see these are the kind of beds that we had there. This is the sort of spacing that we had between the beds. And this is Nurse Karine moving one of the oxygen concentrators to a patient who needs oxygen. So you can get a bit of a sense of the types of conditions in which patients are receiving care in Bambari. So that is all from me. I'm so sorry that I can't answer your questions. I'm sure that others will do a fantastic job of it, and have a nice evening.